Hello and welcome back to Yale, Conversations Worth Bringing Home. I'm filmmaker Arthur Musah, and today's guest is someone I've known for a very long time, going all the way back to our college days a couple of decades ago. And I honestly can't say this enough, but Dr. Yehoda Martei is one of the most genuinely caring people I have ever met. And she's also one of the smartest. Um, Yehoda is a medical oncologist and a professor at the University of Pennsylvania. But what's always fascinated me about her work is how she's chosen to shape it. She's built a career that doesn't just live in one place. Her work moves across North America and Africa. She's from Ghana herself, like me originally, especially in Botswana. Her work in Africa is primarily in Botswana, focused on improving access to cancer care and closing the gaps in breast cancer outcomes where resources are limited. And here's the part that really grabbed me. Some of her research isn't just about drugs or protocols or systems. It is also about story, and about how survivor narratives told in the right cultural context can actually reduce distress and help patients access treatments. In other words, she's working at that incredible intersection of medicine, equity, and human experience. So today we're going to talk about how she found her way into oncology, how systems and power shape who gets to survive, what it means to practice medicine across continents, and why storytelling might be one of the most underrated tools in healthcare. This is exactly the kind of conversation Yale exists for. Now, she's been my friend for a long time, so I usually just call her Yehoda. But today in this space, I think she's earned Dr. Mate. Dr. Yehoda Mate, welcome to Yale.
Thank you, thank you. And you can call me Yehoda going forward. Thank you. I feel really honored to be here. I've seen a lot of artists and people in film production on here, and so, you know, I feel like I have earned some credit in that space by being here, but really a pleasure to be able to chat with you about my work.
I'm very honored that you said yes because trying to switch it up and have a little bit more of a broader conversation. And so this is the first one that is touching on the medical space. So maybe we can get right into it. I like to start sort of at the beginning of people's stories. And so I'm curious about what your childhood was like and what did you want to be growing up?
Hmm. So, as you know, I grew up in Ghana, and I think I grew up with three girls. My sisters, I grew up with, I guess, my sisters, two sisters, and my mom. And so it was mostly a female dominated household. But I just grew up with a sense of admiration for just like women and the different roles women occupy, but then also admiration for like the community of like having sisters and I think that sisterhood and friendship is just really different. And it sort of carried me throughout life in terms of the communities of I form throughout my education trajectory, my mentorship, the way I mentor people. I think it's been that sort of common thread. But then growing up in Ghana, I think when you're in school and you're smart, everyone thinks you should be a doctor. And so I think growing up in Ghana, a part of me thought I wanted to be a doctor, but I think it was mostly informed by what other people thought. And so I didn't really get a sense of, being a doctor until after college when I was actually processing it for myself and what it meant. But I would say one of the most formative years was actually attending Wesley Girls High School in Ghana. I know it gets a lot of bad rap and also hidden in the admiration for really raising women who are confident and sort of future leaders in their own right. And I didn't really experience, sort of saying that growing up in an all-female household, I didn't really think of the world as having different dynamics for, people based on like their gender or their race. I mean, obviously in Ghana, we'd even think about race. But even as a woman, I didn't think there were sort of limited spaces you could occupy. And then I went to Wesley Girls, and when I reflect on my education there, I think there was an intentionality in raising girls who would be future leaders. There were things that I didn't appreciate then that I thought were just like culture or just like nitpicky. They thought about how you should present yourself in a space, how you walk into a room, what your body says about how your position is, how you take up space, how you eat, how you interact, how you pose. And it just seems trivial.
Mm,
But I think, and it seems trivial, and I thought it was just the culture, but I think embedded within that was this realization that as a woman, there are spaces that you can claim as your own, but also realizing that the world is going to judge you based on just like little things here and there. And so in their educational approach, they not only, train people to be academically, rigorous. There isn't just academic rigor, but there's also sort of the cultural, almost grooming
mm,
of women to be in leadership roles. And I say this because anytime I've read about a woman in Ghana who is in a high position, a leadership role, like 9 out of 10 times they went to Gehe. And I don't think it's by chance. I don't think it's because we are teaching something academically that others are not getting. I think it's the
mm.
extra that focuses on raising women to be leaders. And at that stage, I don't think you get it as much. But when you reflect back, I think a lot of the training we had there is really formative. And it also helps you then develop ideas and sort of build on that as you go on. So I think that really is yeah, I don't think that sums up my growing up experience, but those are some of the formative experiences I can think of.
No, that actually really opens up. I feel like, I mean, I knew you went to Gehe, but I didn't realize the ways in which
Mm.
that particular school, the culture there, shaped who you became. Um, so I guess medicine was always something that people or the community, society, maybe family even, um, kind of pushed you towards, right? Because you had the academic prowess. What else did you consider when you were challenging yourself to actually figure out what you wanted to do? Were there other professions or things that you considered? And
I
how
think they
did you
were
decide
all,
medicine was actually appropriate?
yeah, I think they were all sort of related. So I knew I was curious about science in general. So I think one of the things I thought was whether I just wanted to do research. I didn't at the time realize that people could combine research careers with clinical, roles. And I think I was more excited about answering questions, figuring out why things are different, trying to answer questions. And I think there was an appeal about research that I could study something in depth and be an expert in that field and study it. So not too far from science. I think, and not too far from medicine. I think the medicine bit was really figuring out whether I wanted to do patient care. I realized I hadn't actually had the experience of, family, I just hadn't had an experience of being in a healthcare system, not as a patient, right?
Mhm.
I hadn't actually even been a patient in the healthcare system. I hadn't had a lot of family at that age who were sick. And so my interaction with the healthcare system was very little. And so I was just like, I don't really know what it means to be a clinician, to take care of patients. I don't actually know if I'm going to enjoy it. And so I took time off after college to do some research. And so I worked at Mass General Hospital in Boston, but I got to do research, I got to do clinical work. And that for me helped me meet people who were sort of paving this path in their own careers, so sort of as faculty members or researchers. And I think I was able to look at people I admire and mentors that really gave me experiences in both areas. And that helped me come up with what I wanted. Oncology was exciting because it was the first time that I felt like I could do all the things that I wanted to do in one specialty field. And the reason why I say this was so I was working in a breast cancer research group. Um, and one of the things that we do in oncology is hold tumor boards. So tumor boards are discussions where you have a multidisciplinary team. So like a surgeon, a few radiation oncologists, because as you know, like cancer is not treated by one modality, right? There are
Mhm.
surgeons, there are radiation oncologists, there are radiologists who read scans, there are pathologists. And so, for a lot of disease sites in oncology, we have tumor boards where that multidisciplinary team comes together to discuss complex cases. And I found that so fascinating because it was just like having all these incredibly smart people thinking about the appropriate care for a patient. And not only that, I thought it was also exciting to see that the research that was coming out of the journal articles were being directly translated into clinical practice. And so when I reflect back now, the therapies that we use, immunotherapy, all of these like weren't even there when I was in med school, right? But to see therapy transform that rapidly, to see the uptake of that translate into patients living longer is amazing. And I just wanted to be in a field that was that dynamic. It was that dynamic that patients were living longer, but I could also do research and answer questions around things that I was excited about. I didn't have to be siloed. I didn't have to work with my specialty all the time. I got to interact with surgeons still. I got to interact with other specialties. And I think um, I don't know. If I did something else, I'd probably be bored. But just being able to do this in a field that's constantly changing, requiring you to constantly learn new things, new therapies, I think it's exciting. It's even at that point where I'm just like, oh my God, I can't even keep up with all the new therapies. I think that's exciting for patients, right?
Yeah.
And this is why like it's important to fund research because the research drives new therapies and it helps patients. But I definitely wanted to be in the mix of that excitement, to be able to be in a field that was literally constantly evolving, not like decades, like, every few years there's a new therapy that really changes our whole perspective on how we treat patients. So that for me was super exciting.
And was it through some sort of rotation on the internship that you kind of discovered oncology and learned that there was this whole world that appealed to how
So it
you?
was like a complete 2 year gap year. So I took a gap year after college. So I was working full time. This was like my first full-time job. So for 2 years, I lived in Boston, and I worked in this department. It was really a research, um, I don't know, assistant role, but then I ended up making more of it. I had incredible mentors who I'm still in touch with, and they took me under their wings and really sort of gave me that exposure to the different aspects of oncology. So I think just being embedded within this for 2 years, I didn't have any of this experience in college, and I think if I did, it would have changed my perspective. But college isn't really structured that way, and so just having that 2 year gap year was like really convinced me that this was the field I wanted to go into. I was super excited. I couldn't think of myself doing anything else really.
Okay. So Gehe kind of gave you a background. I mean, first of all, your family
Mhm.
was this rich community of women, right? And then Gehe or Wellesley Girls
Wesley Girls High School. Get it
Wesley
right,
Girls
Arthur.
High School uh, kind of built on
Mhm.
that foundation that you got from your family, from your sisters, from your mom. And then you came to the US to attend Harvard for undergrad. You got your bachelor's there. And then you took 2 years off, did this job at MGH, Mass General, where you discovered oncology. What do you do next?
So then I went to medical school after that. So I went to Yale for medical school and also really it was an exciting, I mean, people look at med school and they're hard years, right? You're studying like completely different language and really anatomy and physiology and things like in depth, right? But I also think that for me, my medical school experience was fantastic because I was fortunate to be in a class. So it's usually a class of 100 or 110. But I was fortunate to be in a class where 20% of us were either people who identified as minorities or were international students. And so it was really, an enriching experience to be able to study medicine with people with very different perspectives, very different upbringings, but really bringing into our discussions and our perspectives about healthcare and health equity. You know, Being able to reflect on that because of our backgrounds, I think was an enriching experience. And then sort of talking about this whole community of women and supporting each other. I think I was fortunate enough that in medical school I had that community as well. So I had a community of friends who are still my friends who used to watch America's Next Top Model before we studied anatomy and did epi. So I think it was just being able to learn in a community that was supportive, where I also was surrounded by people who looked like me and some who had similar experiences, uh, experiences that were similar to my upbringing. And so medical school can burn you out. I think it can cause burnout, and people drop out of med school and take time off. But I think really having that supportive community for me was important, and it also taught me skills about resilience and just how I function in high stress situations and building coping mechanisms, which have then sort of carried me through the rest of my career.
Did you pick that particular medical school for these qualities, this diversity of maybe people from minority backgrounds, or did you just kind of lack out to
I think I
one
just
place?
lacked out,
Okay.
actually. I just lacked, our class just lacked out. So I didn't pick it. I picked it because Yale at the time didn't have grades. They had sort of a pass-fail system, and classes weren't mandatory. And I was the sort of person who studied at my own pace, and I had a different style. And so I didn't need the structure. I was motivated enough. I knew what I wanted to do. And it's sort of self-selected, right? It's selected for people who didn't need the rigid structure to thrive and excel. And so I like that structure. I like the flexibility, but I knew I was driven enough that I would be fine. And so that was actually the main reason I chose Yale, and then got there and realized my people were there too.
The extra bonus, right?
Exactly.
And I asked that question specifically because I feel like that wasn't necessarily always the case after Yale.
Mhm.
I don't know if you're comfortable talking a little bit about, how the Yale experience and having a rich community of people from minority backgrounds was contrasted against maybe your experience in the later stages of your medical training, like in during a fellowship when maybe there were like two Black women. Um, you know, are you comfortable talking about that at
Yeah,
all?
I mean, I do think that like I said, we lucked out because I don't think it's a surprise really, and it's a known fact that Black women, Black men are really Latina men, women. I think there's just an underrepresentation of minorities in medicine, right? Our specialty has, I don't know, 2 to 4%, maybe Black oncologists. And so I don't think this is surprising. Like I said, I feel like we lacked out at Yale because really throughout my training, it's just been that percentage. You're either the one or one or two Black people in the fellowship class or in the residency class. Um, and I think those are shared experiences that a lot of Black women or people of color or minorities face, is that a lot of the top tier academic institutions are going to have people who are mostly white. But I also think that, depending on the subspecialty, you often don't have adequate representation. And we can debate about what adequate representation means, but like 2% of Black physician oncologists is not really adequately representative. And so yeah, I feel like truly lacked out with Yale, but it also gave me sort of the foundation and the resilience to believe in myself, to believe in what I'm capable of. I saw other incredibly smart women from different backgrounds who looked like me, who didn't. But I just think being able to see people achieve at their maximum potential, regardless of what they look like and what they bring into the table, I think was inspiring because I didn't doubt myself going forward, right? I was just like, I have seen people that can do this, who are excellent and have become brilliant doctors. And so it gave me the confidence and the assertion that I can really, contribute to whatever space I'm in, but then I also belong. It helped me overcome. I don't really think I ever felt like imposter syndrome. Like I have a healthy sense of doubt about things, but not that I don't belong. Of course I belong, My parents said I belong.
Yeah.
And so I think that having that community earlier on in medical school was definitely grounding. And I think it's just sort of, helped me um, throughout my career, but I've also had that community that I can then lean back on when I run into troubles or challenges or just want to talk to someone who has a shared experience that I encountered either in the clinic with a patient or something, it's good to be able to, reflect on that with someone who understands this experience. So I think it was great, but we obviously lagged out because the rest of my training has been that sort of one or two, being the one or two in a sea of, mostly predominantly white people.
Okay. So maybe could you tell us a little bit about what you do right now and how you've set up what you do right now in the US and in Botswana?
Okay, um, so I'm in academic medicine. And in academic medicine, it means you occupy sort of different roles in medicine. So I see patients, but it's actually not the most of what I do. So 25% of my time is seeing patients. So I see patients who are admitted to the hospital with different complications of their cancer therapy or their cancer treatment. And so I do see patients with different diagnoses. It can be breast cancer, it can be lung, it can be GI cancers. That's what I do clinically. But that's a minority of my time, and that's 25%-ish of my time. The majority of my time is research.
Mhm.
And so my research funding has been mostly focused on global projects. So my global project, which I have spent most of my research building, is in Botswana. And Botswana, because Penn, so where I work now, has a long-standing relationship with Botswana that started with the HIV epidemic and research and clinical infrastructure, and that was built around that. And now there is a desire, sort of policy-wise and from a research perspective, to expand that into cancer care. And so a lot of my research has built on that infrastructure. And so I do research in Botswana, and that means having a research team that's based in Botswana, but I also travel to Botswana. My travel was a bit sporadic initially, or not sporadic, but just wasn't as coordinated. I now have a 5-year-old, so we travel in the summer. I get to do research. And I also get to mentor medical students and trainees, so either fellows or residents who are interested in global research. So I do that as well. And then in the US, I do some health disparities work. So there are a lot of similarities when you think about health equity and disparities, right? I feel like in the way, like the domestic disparities that we see is somehow amplified in the global setting. But a lot
Hmm.
of the strategies that we think about that work in these settings are similar. Like think about community healthcare workers and their role in potentially being a bridge between patients and the healthcare system. These are systems that work so well. It works so well in different parts of Africa, and Botswana was used for HIV care, and Rwanda. And I'm thinking about how to bring that to the US when I think about our low income populations. And so, in a way, there's been an organic transition to think about, domestic disparities and how some of my research work in the global space can inform that and sort of vice versa. So, majority of my time is research, and then I do a lot of mentorship. I'm so passionate about mentorship. I don't know how much time is allotted to that, because like our roles are divided, but like my research embedded within my research is like training either medical students, undergrads sometimes, fellows, residents, in different aspects of my research. I also mentor people um, from a more career development or professional development angle. And so not necessarily in research, but just, helping them think about their career paths and how to develop that. And I'm especially committed to, mentoring minorities. I mentor anyone, but, I feel very passionate about mentoring underrepresented minorities because I think the way in which we create sustainable change in health equity is by really creating a new generation of workforce that is sensitive to health equity, but also training providers and researchers who represent diverse communities in the US.
Okay. So you kind of touch a little bit on how some of the community-based solutions for treatment in Botswana or elsewhere in Africa is something that you're trying to reproduce here. That was like one of the questions I was curious about. Are there what is being cross-pollinated as you're moving between North America and Africa in your work. What are the ways in which your Botswana practice is changing how you do treatment and medicine here, and how your American practice is affecting your research in Botswana?
Yeah, I think so. That is okay. So maybe I'll just give, I think so. I study disparities, right? And really, disparities is thinking about how people with the same cancer might have different outcomes because of where they live,
Hmm.
or just like all these lived experiences that affect how people access care and affect their health outcomes. And
Okay.
so being able to practice in the US and also in Botswana, I see the same cancer types, literally same patient, not same patient, but same cancer type, same age, same cancer, but treated totally different because of differences in access to cancer medicines, what's available from a resource perspective. But then at the same time, I get to practice in the US where I see disparities even within the US.
Hmm.
And so it's not just, oh, they do things differently in Botswana than the US. It's just even within, even in Philadelphia, two patients aren't really the same. A patient from West Philadelphia who has, I don't know, makes $25,000 a year and has like several barriers to care would access care differently. They might
Hmm.
not get on that clinical trial. They might miss appointments. And so I do think that the global perspective sensitizes me to that sort of lens that care is different based on people's lived experiences, because you see that sort of amplified in the global setting, but it helps me look at that locally. When I think about like how research ideas cut across, I think about interventions that address that sort of lived experiences. And so in Botswana, we're thinking about how to increase education and destigmatize, cancer, like perceptions around cancer in the community. And through talking to providers and patients, what came through was that patients wanted to hear stories of survivors, of people who look like them. So like I thought I had like all the textbook answers, and they're like, no, we want to hear from another survivor. Like, tell me
Hmm.
that patient who survived. And so I think that was powerful because a lot of the times we focus on, the metrics, the data, and really what patients want to hear is someone else who looks like them, who is their neighbor in their community, who went through this and survived. I think historically, a lot of our educational materials have been, translated materials from the US, but like
Hmm.
people don't believe the story of someone who was treated in a fancy facility to be relatable to their story. But I think what helped was that patients were really inspired and empowered about their own potential for survival, like having their lives prolonged with cancer after hearing people who look like them. And I think the same plays in the US. So this idea, we actually then designed a study based on studies in the US that had focused on I think breast cancer patients who were Spanish speaking specifically. I can't remember where it was conducted, but essentially it was just like having patients who spoke the same language, then had these narratives about their cancer journey, and it increased screening uptake for like breast cancer screening and cervical cancer screening. So we thought, can we adapt this and use a local team in Botswana? And it was hugely successful. I mean, people were
Wow.
worried about, is it going to be on YouTube, on the internet? So we
Hmm.
had to, ensure in the research environment there was some privacy restrictions. But I would say it's just been one of those like very gratifying research projects that I didn't go in with that design. I just went in listening to patients, and they wanted to hear from other patients. And I think we don't use this enough. I don't think we leverage this enough. And I think it's such a powerful thing to be able to be seen, to feel seen and be heard. And I think it cuts across in other industries, but we don't do that enough in medicine. And I think increasingly people just don't want to hear from their doctors alone. They also want to hear from people who look like them, and and feel like they're being seen and heard when they come in with their complaints.
That's fascinating. Um, that stories can be that powerful within the treatment of cancer.
Mhm.
Um, have you ever had a patient kind of teach you something that a textbook or a clinical trial kind of missed? I mean, I guess this is one example, but is there anything else that like a patient may have?
Um, Trying to think. You know, I don't know. I think I can't think of like a single patient story, but I think there's the universality of like each patient is ill in their own way. And
Hmm.
I think we usually, you study the script, you know the diagnosis and the next course of action. And usually we get into the routine of saying, you have this, and then this is what it means. But it's usually quoting a lot of numbers and survival and people in your shoes at 5 years will live to blah, blah, blah. And I think what patients have taught me over the years is just like really listening, like, what is important to you, especially in patients who we don't think we can cure their cancer. I
Hmm.
think it's important to understand what is important to you. And it's just surprising, like, and then you have to, respect patients' choices. I think we also project a lot. And so sometimes it's just like, well, I want to do everything possible because I want to see my grandchild being born. Or you know what? I've always wanted to do this bucket list trip to somewhere. So I am not going to do that therapy you said that requires me to come into the hospital every 3 weeks or every 2 weeks. I am going to go on that trip. And I think starting with you have this diagnosis, what is important to you? And how can we make sure that the treatment goals that we set are in alignment with your wishes and your quality of life? And you find that patients have very diverse perspectives, and you can't really judge that. I think people feel how they feel. And I think it's the humility in realizing that you cannot predict like what you would do. Sometimes patients ask you, what would you do in my shoes? And like that's a trick question. Of
Hmm.
course, it doesn't what you would do in their shoes doesn't mean anything. It really matters what they think and what's important to them. I just think really understanding patients' stories and tailoring that, like, the treatment plan and your approach to their, like, what hopes and aspirations they have for their life is very unique. And you can't learn that from a textbook, right? You just have to talk to patients and understand their stories and what they wish for. And then our job really is to help them get there and achieve that within whatever means is possible, I guess, realistically possible.
Okay. How have you seen cancer care in Botswana, but maybe more broadly in Africa, evolve in the last maybe decade or two? Has
Uh,
it evolved?
Well, if it hasn't evolved, I don't know why I'm doing what I'm doing, but I think I think it's changed a lot. I remember in medical school wanting to study breast cancer in Ghana, and so I went to a research search engine to look at publications on breast cancer in Ghana. And I think literally there were like 5 articles, like five.
Wow.
Okay, I didn't go to med school that long ago, maybe I'm that old, but anyway, there were 5 articles. And then now, fast forward, I don't know, like almost 20 years ago, there's been an expansion of the field. I think, first of all, there's the recognition of the global burden of cancer, but also the burden in sub-Saharan Africa. I think we grew up not talking about it, not speaking about it. And so, everyone thought maybe Africans don't get cancer, we don't get cancer as much, but there's now like a recognition that it is, uh, probably underdiagnosed, hugely underdiagnosed. There is a lot of research focused on understanding the biology of the disease that's a little bit different in Africa. So for some setting cancers, people are being diagnosed at much younger ages in Africa.
Mm.
So early onset cancers are huge. There are more sort of aggressive subtypes as well.
Mm.
And we're realizing that people react differently to medicines that were tested in clinical trials that were mostly, enrolled mostly white populations. And so I think there is a lot of emergent research, which is great. It's sort of what I do. But then I think clinically as well, there are more oncologists being trained on the continent. And so now I can think about, people ask me, and also I'm also at that age where like either people are being diagnosed with cancer, unfortunately, or their families are being diagnosed with cancer, and people ask for recommendations all the time. And I don't think, you know, decades ago I would have been able to name one person, but now I can think of a few people in different countries who are practicing. So I think it's definitely a field that's growing. There are a lot more oncologists, not just being trained in Europe or America, but actually training programs on the continent as well, specifically to address the cancer burden. And so I would say it's evolved a lot. There's increasing recognition, increasing research, increase in clinical care. Access to medicines is still a challenge. People have to pay out of pocket. So that's huge. Even in the US, people cannot pay for medicines out of pocket. So to expect people to do that is, this just it's what we call financial toxicity. I mean, people go
Mm.
bankrupt really from a cancer diagnosis because it's hard to afford those medicines. And so I think that remains a challenge. It's still a challenge. There's still, even with this awareness around cancer, there's still a lot of stigma surrounding cancer as well. And so there's some things that seem persistent. I published about breast cancer stigma when I was in medical school. I did this research in medical school. And it took me a while to publish the paper because I was like, oh, I bet like there isn't that much stigma. And then I did research in Botswana a few years ago, and there's still a lot of stigma around a breast cancer diagnosis, right? And so I do think there's certain things that are still haven't changed yet.
Mm.
But overall, I would say I'm optimistic. I think the landscape is changing and in a positive way.
Okay. Um, what do you think the most important story about cancer that we're not telling?
Hmm. Actually, I know that, I think. And this is sort of related to cancer stigma. I think we're not talking enough about cancer. I'm not saying, everyone should talk about cancer, but I think we should share cancer stories more openly. And I say this because I think the more we share, the more it normalizes it. I think there's a lot of stigma, and so people suffer in silence and isolation and pain, and we don't talk about it, right? I think it's tragic enough that you get diagnosed with cancer, through no fault of yours. And then for people to ascribe blame to you for your own diagnosis, and then to suggest, you buy a coffin because you're going to die. I just think there's a lot we don't talk about. And I think it's related, this is all sort of related to the stigma, but I do
Mm.
think we need to talk more openly about it. So I think we need to talk more openly about it, but we also need to share stories of survival, right? Not everyone who has cancer dies. And I think the only stories we end up hearing are of people who died from their cancer. And so that sense of like cancer fatality, that people die
Mm.
from their cancer, it's not out of ignorance. It's because literally people only know of people who've died from cancer, and in a very tragic and dramatic way or in pain, just stories that don't tell the full picture about how far we've come in cancer treatment. And so I think we need to tell those stories. We need to tell those stories of survival. And I think we need to do that also so that people know their family history. I always have this joke that, we see either immigrant populations or cancer patients in Botswana, and you're like, oh, do you have a family history of cancer? And they're like, oh no, of this. Oh no. And I'm just like, oh no, because no one is talking about it.
Mm.
And so, but that affects, patients and what you can do in terms of preventative health. Because if you know you have a family history and you know at what age people had different cancers, and this applies to other diseases, then you can take, preventative measures, either more aggressive screening measures, so that your cancer, if you were to get cancer, will be detected at an earlier age. But we don't talk about it. We don't talk about, I don't know, maybe we talk about, I don't know, cardiovascular disease. I don't know, but there's a taboo around cancer. We just don't talk
Mm.
enough about it. And so I think we need to talk about it and share the family history. I know our African family tree is complex. I was just at a book club recently and I was saying People don't talk about their family history, A, because it's a taboo, but B, the person you think is your father might not even be your father. So, like, even if you knew, you don't know whether biologically the family tree that you have is really, the family tree that you are using to define your cancer history. But
What book were you guys reading?
uh, The Secret Lives of Baba Seji's Wives.
Okay.
So you can see that naturally.
I must check it out. So I know you wrote a paper recently about basically calling out how there are all these like clinical trials for drugs, for medicines, for cancer treatments that so grossly underrepresent Black people. Could you talk a little bit about that? Like, what did you see in your research, and why is it an issue?
Yeah. So this is actually an op-ed that I wrote. The original research was presented at so we have like a large cancer meeting that occurs every year. So the original research results were presented at that meeting. And it's for like a really efficacious drug, so a drug that works really well. But then as the presenter was rounding up their presentations, they were like, and one of the limitations is that we enrolled 0.6% Black women. And for me, I just felt triggered, right? Because I'm a Black woman, I've had a diagnosis of pre-breast cancer, pre-invasive breast cancer. I know women who are Black women who are my friends. So these are not like random patients who I meet in that clinical setting, but these are people I know with breast cancer. And so when I saw that 0.6% Black women for a breast cancer trial, I just felt tricky because it's like this is outrageous. There is no way that in 2026 we should be enrolling 0.6% Black patients in a breast cancer trial. And then as I looked further, I realized there were more men enrolled than Black women. And we consider breast cancer a rare cancer in men, right? It's not that it doesn't happen, it does happen, but it's considered rare. And so all men, Black women, I thought was just scientifically egregious. It was like unethical as well, right? Because we are moving towards precision medicine, which hopefully will help us see a patient in the clinic and to be able to tailor therapies to their exact biology and predict how they are going to react to the disease and to the drug in terms of toxicity. But if you have a trial that is predominantly enrolling women who are not Black, then you have this, translation into clinical practice where you're treating patients who are Black women with a drug that wasn't really tested in them. And so, is it truly representative? I don't know. I just felt, I think we can do better. There have been trials that have enrolled more women, but I think if we are going to have a drug that's FDA approved, we need to enroll populations that are representative of who gets breast cancer. Like if you ask who gets breast cancer, like Black women have worse mortality from breast cancer compared to white women. And so I think it was alarming for me. And I thought, I would see news articles or people talking about it, but just life moved on. And I just felt like it was the thing I couldn't move on from. It's been what, since that, and I shopped it around a little bit
I'm
and
sorry, I think you dropped out for a little bit. So that's
oh,
something
got
you
it.
just couldn't overlook.
Yeah, yeah, it was just something I couldn't let go. I thought, other people would talk about it or there'll be a commentary about the publication, but I didn't see anything. And I just, I think we all pick the fights. We're just in a climate where you can't pick up every battle. But I think this is the thing I was passionate about. My research is focused on this. My passion for, mentoring underrepresented minorities is focused. There's a lot that intersects with this trial and how it underrepresented. It was under how Black women were underrepresented and things that are just like very core to, what I want to do in medicine and what I do in medicine. And so I wrote an op-ed about it. And I didn't want to write another journal article that would be buried. I wanted to write a lay article that anyone could read and see that Black women are underrepresented. And I'm hoping that it generates sort of renewed dialogue and interest about it, but also hope that, the Black women who are reading that, I know that several barriers and mistrusts and a lot of barriers that we have to overcome in order to enroll representative populations. But I hope, people read that and the next time someone asks them if they want to join a clinical trial, they think about ways in which, maybe they can work with a social worker or the navigator to overcome some of these barriers in order to enroll in the trial. But I don't think the burden should be on Black women. I think, industry sponsors, researchers should do better in terms of putting systems in place to ensure that we can have a more representative enrollment in our clinical trials. Sorry, that was a really long-winded
No, no,
answer.
no. No, that actually you covered something I was going to ask, which is, do we have an understanding or, any insight into what the obstacles are? And you kind of touched on that. So yeah, it sounds like the issues are systemic, and therefore maybe, we need to start fixing those systems. Was there a moment in medicine when, science and all these solutions became more about systems, power, and access than just medicine? Can you identify a moment where that shift happened for you?
Yeah, I think in residency maybe. So I did residency at University of California, San Francisco. Um, and we get to practice in different hospital systems. So we get to practice at the main hospital, at the VA, the Veterans Hospital,
Mm.
and then also at the Safety Net Hospital, which has a lot of um, it's a safety net hospital. So really, people who are uninsured, underinsured, recent immigrants. But I think, for me, it was just realizing how, I think it was the first time that it really hit me that people who live within the same city can have very different um access to medicine. Like we were literally the same providers going through these three hospitals. But the patients that you see are so different. You go to San Francisco General Hospital and you're seeing patients coming in with miliary TB and it's like, like just or like advanced presentations of, and I don't want to say these are like the cases I see in Botswana, but in a way, you're just like just across the street, they're like having women with like sub-centimeter tumors. And here, the women presenting with fungating masses. And so I think it just made me realize how, and the US system is unique in that way, but it just made me realize how poverty is just like one of the biggest determinants of health. Like that shapes the kind of care people get in the US fundamentally. And it doesn't play out, sort of on a macro scale where you're like, oh, in urban cities, people get this care, and in rural areas, they get it. Like even within the same urban city, within the same hospital affiliation, there's sort of different levels of care that people get based on their insurance status, based on what's covered within their insurance status. Um, and and so I find that, that's something I still struggle with because I think a lot of academic centers have those sort of multiple partnerships where some of their hospitals, cater to a certain catchment area and other hospitals cater to, more well-insured populations. But it's unsettling because you go in and out of systems where you do see people get very different cares and the insurance system is a huge part. I mean, I think one of the things that we realize is that the Affordable Care, the Obamacare basically, was able to bridge a lot of the gaps that we'd seen in screening and cancer care access, having Medicaid expansion under the ACA. And so I think part of it is just like political will to provide adequate insurance for most Americans. And as you know, a lot of things about healthcare is now being highly politicized. So I think that's a challenge, but ultimately, I think poverty, people's lived experiences where they live still dictate like their outcomes from cancer. And I think that's really disturbing for me.
Okay. Um, so you went to Gehe in
Mhm.
Ghana, Harvard. Yale, UCSF, and you currently work at UPenn. How did those elite spaces prepare you for the work that you do? And I'm also curious about what things in your individual background, maybe for the, let me just call them superpowers that you bring to your practice as a woman, as a Ghanaian, and any other specific. What ingredients from those two pieces of, your training and your background n- do you bring to your work?
So it's that's a difficult question. I'm trying to understand. Um,
So I guess, is there something that, your
yeah,
training didn't really equip you with, but because of who you are,
yeah.
comes
Oh,
in handy in your work?
yeah. I think the being in having gone to sort of top tier academic institutions, um, I do think that it's sort of double-edged, right? Because
Mm.
I do know that I have good training. Like I know I have excellent training, whether it's pre-med or medical school. I know I've been through institutions that have trained me well. I also know that I've been through institutions that don't have representation of people who look like me. And so when I say that's double-edged, it means it comes with a burden of feeling like you're representing a whole community, right? It's just like, I don't want to be the black voice for every black, like we are, like being black is not a monolith, right? Like, they're just like very diverse experiences. And so I don't want to be the black doctor that can speak on everything related to the lived experiences of black people in America or the lived experiences of immigrant people from Africa. And so I just think there's a burden to do, in a way, it's sort of minority tax, being on communities that are geared towards minorities, geared towards women empowerment, geared towards like basically anything related to Black empowerment or minority or any sort of health equity focus feels like something that you should be involved in because you're like, who else? Because, either you or the one other person are the only people of color. But I think over time, I have just also realized to sort of pick my battles. Like I can't, I think part of being able to engage in all of these initiatives is to be able to take care of myself as well, right? And I have a young family now, and so increasingly I've just been protective of you know, that family as a way to sustain my joy, focusing on community that's outside of work. Like I just don't want my life to be defined by my work and the challenges. And I think being able to have and again, maybe it goes back to like, growing up with girls, but, I've just sort of naturally been able to find another community of people or women who I find, I derive inspiration from, who really inspire me with their work, their research, but even the way they balance family life, right? And so I think being content and realizing that I am enough, like what I am doing is enough, has put less pressure on me to want to be in all these spaces doing things for minorities. I do realize I cannot do everything, and that's okay. And I also think, like we said earlier, a lot of the issues are systemic. And so to expect the one Black person or the minority person to fix these issues, I think is also unrealistic. And so the things that I'm passionate about, but I also feel confident when I have to step away from something because I'm like, it's the weekend and I am doing something with my family. And I am perfectly okay with that. I have no guilt about it because I know the things that I fight for and the things that I'm passionate about. And I do realize, I can only solve like, you know, a piece of the puzzle, a slice of the pie, or whatever it is. But I think there's usually an undue burden on minorities because you just happen to be the only or one of few people in whatever space you're in medicine, and
Mm.
the burden to solve that problem, but realizing that, you know, A, that problem preceded you. B, it's built on like systems that have been built over decades, centuries, that you cannot solve alone are important reminders to take care of yourself and also focus on what you're passionate about, what aligns with your vision, and what you cannot change, and and take care of yourself. So I do a lot of self-care, and I am very happy with that.
Yeah. So being focused on the brick that you are rather than trying to be the entire wall or architecture of the whole system. Um, so maybe to wind down, I have one question
Mhm.
with the perspective of like thinking what might be encouraging to people, especially younger people that might be coming in the footsteps on the path that you may have traveled, and others like you may have traveled. What advice would you give to your younger self?
Ooh. Um,
Was there some particular anxiety or worry you had, maybe in high school and secondary school about how life would turn out, and
yeah.
there's a wisdom from where you are now that you wish you could pass down to that Yehoda Mate who was at
You
Yale.
know what? You know what? Actually, yes, yes. I think I mean, this sounds rather banal, but like, we always say, oh, things always work out.
Hmm.
I think being an international student in the US, I mean, now the hoops are different, but being an international student in the US meant that after graduation, I had to worry about like a job and OPT, and it worked out. Then I had to worry about H1B, and that worked out. And then like just all the different phases.
Yeah.
And even, through the F1 phase. And I think there's just a lot of anxiety as an international student that adds to just the stress of going through medical education. You also have to worry about, maintaining your visa status in the US at each and every step. And I don't think people appreciate how stressful that can be. I mean, now in this current climate, I can't even like begin to comprehend how crazy that must be. But and maybe it sounds too simplistic to say like everything works out. Like things work out the way they were meant to. But I think, just not being anxious, trying to control the things that are within your control, and the rest will work out.
Okay. Thank you, Doc. This
All
has
right.
been
Thank
an
you.
illuminating conversation for me, even though I've known you all this time. And I'm hoping it will be interesting to the Yale audience as well, or people that encounter it. I mean, the show's pretty new, so people encounter it on YouTube and on social media as it goes out into the world. But I'm really grateful that you made time for us this evening. Thank you so much, Dr. Yehoda Mate, for a conversation that reminds us that cancer care isn't just about medicine, it is about systems, stories, even. And the simple but radical idea that where you live should not determine whether you survive. Uh, I'm excited that your work exists in this space. I'm thankful that you shared a little bit about your work with us today. And to our audience, if this conversation stayed with you, share it with someone who should hear it, and join us for another episode on YouTube. Subscribe. And I'm Arthur Musah. This is Dr. Yehoda Mate, my guest. Thank you so much for watching.
Thank you. Thank you for having me. This is great.